A very good evening to all. I am Dr. Nandakishore, working as a consultant critical care at Medicover Hospital, High Tech City. And I welcome you all to this monthly academic program conducted by the ISCCM. And as a part of this renal series, I will be discussing in the next half an hour about the various aspects of hepatorenal syndrome. As a whole, if you look at the hepatorenal syndrome, the acute kidney injury in any aspect itself is a very big challenge as far as critical care is concerned. And as we know, day-to-day practice, dealing with cirrhotic patients itself is an extremely challenging scenario. And when a cirrhotic patient who is a decompensated form develops any form of acute kidney injury, it's even challenging to manage such patients. And in the next half an hour, I will take you into the various aspects of this hepatorenal syndrome, the various pathophysiology of aspects, the diagnostic criteria, what changes have they brought to the diagnostic criteria, the understanding of the entire physiology of this hepatorenal syndrome, and the treatment. So before going into the case scenario, I would like to discuss, before going into this hepatorenal syndrome, I would like to take you to the case scenario. We have a 50-year-old male who is a non-ethanolic, diagnosed as CLD 2 years back, presented with a history of vomiting, abdominal pain and distension, and jaundice since 2 to 3 days. And he also has decreased urine output since the last 24 hours. And history revealed that he was admitted previously with the similar complaints 2 months ago. When you examine him physically, he is drowsy, slightly in altered sensorium, probably in hepatic encephalopathy. He has an abdominal distension, icterus, and bilateral pedal edema. He is hypotensive and tachycardic with a blood pressure of 90 by 40 milliliters mercury, and he is tachypneic with respiratory rate of 30, maintaining saturations at room air. So basically, this is a typical kind of cases which we see day in and out in our intensive care. When a decompensated CLD patient comes with some form of decompensation due to some frustrating event, and this is the picture what you actually get in a real life case scenario. So in the ER, you see this patient, you observe that this patient is in hypotension. Immediately you start him on fluid resuscitation, and after giving 1.5 liter of fluid over 2 hours, he was initiated on noradrenaline and targeting a MAP of 65. He was anuric at the time of admission and continued to be oliguric despite adequate fluid resuscitation. And gradually this patient noradrenaline requirements went up, and gradually there is addition of another vasopressor in the form of vasopressin. ABG showed severe metabolic acidosis with an elevated lactates, and you send all the relevant investigations and ship this patient to the ICU. This is what you have done in the emergency. And at this stage, I want to ask you, is this patient having hepatorenal syndrome, or do you label this patient as a hepatorenal syndrome? What is the diagnosis of this patient? Is this patient having hepatorenal syndrome, and what could be the probable reason for his renal compromise, and how do we treat him? So what is the definition of hepatorenal syndrome? Do we have a specific criteria to define a hepatorenal syndrome? People have thought to make this definition more easier, and they have formulated a consensus criteria in 1996, that is the International Ascitic Club definition. They have formulated a diagnostic criteria and to make the hepatorenal syndrome diagnosis easy to the clinicians. In this 1996 criteria, they have developed a major criteria and a minor criteria. The major criteria being any patient who has come with a cirrhosis with ascites or an acute or chronic liver disease with advanced hepatic failure with evidence of portal hypertension, they have put a cutoff value for a serum creatinine. The serum creatinine should be more than 1.5 milligram per deciliter, or a 24-hour creatinine clearance of less than 40 ml per minute. And the other important aspect or the criteria is the absence of shock. If you see, there should be an absence of shock in a patient presented with a decompensated CLD and a raise in the creatinine more than 1.5, or there should not be any ongoing bacterial infection. There shouldn't be any concurrent or a recent treatment with nephrotoxic agents. There should not be any component of prerenal azotemia, like a absence of diarrhea or absence of vomiting or extra renal fluid losses. There should not be, and the other important criteria is, the moment you increase the volume or you expand the plasma volume of these patients, there should not be any reversal of the renal function. That means no sustained improvement in renal function should be seen when you expand the plasma volume with 1.5 liter of isotonic saline, is what they have proposed into the major criteria. The improvement in the renal function is defined as a decrease in the serum creatinine less than 1.5 or an increase in the creatinine clearance less than to more than 40. And there should also be no evidence of underlying renal disease in the form of a proteinuria or a hematuria or a ultrasonic evidence of a renal parenchymal disease. And they also formulated a minor criteria stating that the minor criteria: urine volume less than 500 ml or urine sodium less than 10, urine osmolality more than plasma osmolality, and the urine presence of RBCs in the urine. So this is the major and minor criteria which they have adapted to simplify the diagnostic criteria of hepatorenal syndrome. And people looked at and thought this is a little bit cumbersome to apply, and they have revised this criteria again in 2007, where they implemented that patients having cirrhosis with ascites, having a creatinine of more than 1.5, they made one change, adding a resuscitated fluid as albumin. So they showed that if there is no improvement in the serum creatinine after at least 2 days of diuretic withdrawal, we all know patients with cirrhosis are on prolonged diuretics, and when you withdraw these diuretics and the volume expansion is given with albumin and with a recommended dose of 1 gram per kg body weight, and in spite of these precautions, if the creatinine doesn't show any major improvement, then you label it as hepatorenal syndrome. And obviously the absence of shock and the history of no recent or current treatment with the nephrotoxic agents remains the same. So 2007 criteria is more or less same as the 96 criteria, except the resuscitation or the expansion of plasma volume is done with 1 gram per kg body weight of albumin, as well as removing the minor criteria. So basically this criteria is majorly dependent on the diagnosis of exclusion. So you have to exclude the shock, you have to exclude the concurrent causes of acute kidney injury, you have to rule out a ongoing bacterial infection or a sepsis. There should not be any current treatment with a nephrotoxic agents. There should not be any exposure to a nephrotoxic agent. There should not be any component of pre-renal azotemia, and there should not be any sonographic evidence of an underlying renal parenchymal disease, is what they have concluded from this criteria. So what are the limitations of this criteria? Why people have gone beyond this criteria? The first and foremost limitation is the defined cutoff values of absolute value of serum creatinine. If you go back and look the slide, there is a absolute value of serum creatinine cutoff value they have put as 1.5 milligram per deciliter. What if patient has a renal failure with a creatinine of 1.2? So this is the major limitation of this criteria. The relative changes in serum creatinine are affected by its absolute values, especially in patients with cirrhosis. As we know, many of the cirrhosis patients, we have sarcopenia, or a lean body mass is very less, which commonly leads to the underestimation of the kidney function. And also there is an increased tubular secretion of creatinine, which has been reported in cirrhosis, and this can lead to a underestimation of the loss of GFR. And if you see the estimation of creatinine is commonly estimated through calorimetric assay, which we call it as a Jaffe's method. When you estimate creatinine value through this Jaffe's method, people having hyperbilirubinemia can interfere with this calorimetric assay, showing a falsely low values. So whenever cirrhotic patients have a high bilirubin value, the serum creatinine tends to be a little bit low, which is absolutely false. So the first and foremost important limitation of this ICE criteria is the absolute cutoff values or a defined cutoff values for a serum creatinine level, which is practically not possible. The second important limitation is obligatory elimination of the volume depletion. If you see the criteria in the first 1996 ascites club criteria, they have they have expanded the plasma volume by giving 1.5 liters of isotonic saline, which was subsequently changed to albumin. But the magnitude of volume expansion prescribed is not tailored to a particular volume status of each patient. Neither they prescribed a particular endpoints. There are no particular endpoints. If they would have told that I would give an albumin of 1 gram per kg, targeting a MAP of more than 65, that could have made a sense. So no hemodynamic parameter is used to determine whether the patient has reached the optimal intravenous volume expansion, and they didn't use any static or dynamic parameter, and they just fixed to a arbitrary value of 1 gram per kg of albumin or 1.5 liter of isotonic saline, which is absolutely not convincing. So if this continues, it may lead to either a volume depletion or a volume overload. So always a fluid resuscitation in a patient of a background decompensated CLD should be guided by your standard parameters, that is the dynamic parameters of fluid resuscitation. The third important limitation is the absence of recent or current exposure of nephrotoxins. If you see, many patients of decompensated cirrhosis keep on getting admitted to the hospitals, and infections are not uncommon in these patients. You commonly see infections coming into these patients, and these patients are frequently admitted, especially with a spontaneous bacterial peritonitis. And these patients are already being exposed to a lot of antibiotics. If you see this history of these patients, recurrent admissions, they will be either being treated for SBP with an antibiotic, or they will be treated with antibiotic for an upper GI bleed. And the most important antibiotics which are exposed are fluoroquinolones. Of course, fluoroquinolones are used for the prophylaxis of SBP. Cephalosporins, especially the third generation cefatoxime and ceftriaxone, are the current treatment for standard of care for spontaneous bacterial peritonitis and are used extensively in a patient with upper GI bleed. Vancomycin is also used if especially enterococcus is suspected as a pathogen of spontaneous bacterial peritonitis. And all these antibiotics are potentially nephrotoxic, can lead to a toxic acute tubular necrosis, similarly to a sepsis-induced ATN or acute interstitial nephropathy. And majority of these patients with cirrhosis are on prolonged diuretic usage, which are another cause of your nephrotoxic agents. So the other third important limitation is absence of recent and current exposure of nephrotoxins. I don't think this is a valid point, because at some point of time in their course, these cirrhosis patients are exposed particularly to these nephrotoxic agents. And the fourth important point to mention regarding the limitation is the absence of abnormal renal imaging. If you find the findings of abnormal renal imaging, that is the finding renal echogenicity or renal parenchymal changes through an ultrasound, is very, very subjective, especially in patients with cirrhosis who have a massive ascites, which precludes the optimal assessment of renal parenchymal echogenicity or corticomedullary differentiation due to acoustic enhancement. This is absolutely we cannot rely on a single ultrasound finding labeling these patients as a normal kidney size and normal corticomedullary differentiation, which ends in patients in identifying the patients very later, at a later stage. And the fifth important limitation is the use of urinary sodium levels. We all know that low fractional excretion of sodium less than 1% and a low urinary sodium are present in almost every patient of a cirrhosis patient. So, however, in a small study done in 88 patients, they found that fractional excretion of sodium didn't exactly correlate with the diagnosis of hepatorenal syndrome. And of these 88 patients who underwent a kidney biopsy as a part of their pre-transplantation workup, only 11% of them were actually considered to be a biopsy-proven HRS. So still, there could be a component of HRS despite your low fractional excretion of sodium or despite your urinary sodium levels. These markers are just useful for the workup of a patient, but these markers should not be the sole basis for diagnosing a patient and labeling a patient as a hepatorenal syndrome. So if you look at the evaluation of the diagnostic criteria of hepatorenal syndrome, this is a 1996 criteria. They included the major and minor criteria. Later in 2007 revised criteria, they have removed the minor criteria, and they have used albumin as a resuscitation fluid. And in 2015, it has made more advances, and people have looked at labeling this hepatorenal syndrome as a form of acute kidney injury. And what is the most important thing to be observed in this 2015 criteria is, in the 2012, the KDIGO and the ADQI group collectively formed the guidelines of staging of AKI. They have either staged the AKI based on the rifle criteria or the Akin criteria. And people thought, why not we label this acute kidney injury in patients with cirrhosis similar to that of seen in the rifle criteria. So here in the major criteria, they have defined the HRS as end-stage liver disease with ascites. Patients having this end-stage liver disease, they classified AKI as stage 2 AKI, that is more than serum creatinine rise more than the 2 times. And also introduced two terminologies, new terminologies, the HRS AKI and HRS non-AKI, which I will be discussing in the next coming slides. So traditionally, we have been taught different types of HRS. HRS is typically divided into two types. One is the HRS type 1 and the type 2. Type 1, in which there is a rapid deterioration in kidney function, there is rapid progressive renal failure, and creatinine increases suddenly from more than 100% from the baseline to greater than 2.5% within a two-week period. And the median survival of this patient is very low. It is as less as 2 weeks. And HRS type 2, it is seen more commonly in patients with refractory ascites with either a steady or moderate degree of renal function. And median survival of these patients is up to 6 months. Traditionally, we all have been taught that HRS is basically of two types, type 1 and type 2. One is a rapid progressive, which has poor prognosis, and one is a slow progressive, which has a better prognosis. So what is the new classification tells you? The new classification of AKI, they have classified AKI into HRS AKI into two types. That is the HRS AKI and HRS non-AKI. The HRS AKI is more similar to the old classification of HRS type 1, where the criteria they defined were the absolute increase in the serum creatinine more than 0.3 milligram per deciliter within 48 hours, or a decrease in the urinary output less than 0.5 ml per kg for at least 6 hours, and the percentage increase in the serum creatinine more than 50% using the last available value of outpatient serum creatinine, which they take as a baseline value. And the HRS non-AKI, which the previous old classification they labeled as HRS type 2. In this, there are two subgroups, that is HRS AKD, that is acute on kidney injury, or HRS CKD. They defined HRS AKD based on the criteria that your estimated GFR less than 60 for less than 3 months in the absence of other explainable or other structural causes, or a percentage increase in serum creatinine less than 50% from the baseline value. And HRS CKD is labeled as eGFR less than 60 for more than 3 months in the absence of other structural causes, is what they have classified this hepatorenal syndrome. So leaving the classification apart, this is a diagnostic part. You may or may not label this patient as a HRS, but you know that there is an acute onset of kidney injury that is happening in patients with a decompensated liver disease. So whether you label this patient or HRS or not, how do you treat these patients? To treat this patient, you should understand the underlying pathophysiology of HRS. So what is the pathophysiology of HRS? If you see this, if I take an example of a patient who has a cirrhosis with portal hypertension, but yet he is not decompensated completely, there is a compensated form of cirrhosis. There are two theories which can explain this, that is the vasodilatation theory and the inflammation theory. We all know, due to the patients in cirrhosis who have extreme portal hypertension, they have increase in the portal venous pressure, and there is a shear stress through which there is a lot of release of endothelin, nitric oxide, endogenous cannabinoids, and these agents are released into the circulation, which causes splanchnic vasodilatation, leading to a effective hypovolemia. That means the circulating effective blood volume reduced. The moment this happens, the body tries to counterprotect it. How does it counterprotect? It activates the vasoconstrictor systems. It activates the various vasoconstrictor systems, that is the renin-angiotensin aldosterone axis. It activates the sympathetic nervous system, which leads to compensatory increase in the cardiac output. And this activation of these vasoconstrictors leads to a maintenance of the high cardiac output. And still, even if the kidney is susceptible to ischemia, but the GFR is maintained. So the body tries to maintain the GFR despite an effective loss of effective circulating blood volume, despite an increase in the vasodilatation. The body still tries to cope up in some way due to a compensatory mechanisms of activation of the RAS and sympathetic nervous system. So the same thing if you apply to a decompensated patient who is advanced cirrhosis with a portal hypertension, who has already been recurrently being admitted as our patient. So there is, apart from an effective vasodilatation of the splanchnic circulation, that there are other precipitating causes. For example, an upper GI bleed, where you are further reducing the effective volume of these patients, where the patients are being treated for a long-term basis on diuretics, where a patient can develop an acute gastroenteritis or a vomiting. These are the precipitating factors which further cause reduction in the effective circulating blood volume. At this stage, obviously the body tries to counterprotect by activating these vasoconstrictor systems, but the compensatory mechanisms are not as good as in the stage of a fully compensated cirrhotic phase, because the activation of vasoconstrictor systems may not lead to the increase in the cardiac output, because already there is a component of cirrhotic cardiomyopathy, and patients who are having advanced stage of cirrhotic liver disease or end stage liver disease may actually be having a compromised cardiac function in the form of a cirrhotic cardiomyopathy. And the activation of these vasoconstrictor systems is not sufficient to maintain the adequate cardiac output, leading to the loss of cardiac output, decreased renal blood flow, and ultimately leading to the decreased GFR. If I put an entire pathophysiology into a single nutshell, the most important point to understand in the pathophysiology is the splanchnic vasodilatation. Whenever a patient has a cirrhosis, there is an increase in the intrahepatic pressure, there is increase in the shear stress, lot of vasodilators are released into the circulation, which leads to splanchnic vasodilatation, reduced effective vascular resistance, reduced circulatory volume, and the mean arterial pressure, which again leads to compensatory activation of the vasoconstrictor systems, that is the RAS and the SNS. This leads to increase in the renal vasoconstriction and decreased GFR. The other important thing is, as I told, is the hepatorenal physiology. There is an intense increase in the vasoconstriction, and the responsive to vasoconstrictors like endothelin, the norepinephrine, the angiotensin II, thromboxane A2, and adenosine, which are released into circulation in huge amounts in patients with CLD, again reduces the renal blood flow and reduces the GFR. Of course, the hepatorenal syndrome, there is a high output cardiac failure, there is cirrhotic cardiomyopathy, again leading to decreased renal blood flow and decreased GFR. And the hepatorenal axis, where the adenosine and serotonin are released, which again leads to decreased renal blood flow. And the entire thing, whether it's an inflammation, whether it's an infection, whether it's a cholestasis, whether it's an antibiotic induced nephropathy, whether it's a nephrotoxins, whether it's a chronic glomerulonephritis, acute glomerulonephritis, chronic long-standing adrenal insufficiency, you name the cause, the final common pathway is sustained vasoconstriction of the renal bed, leading to decreased renal blood flow, tubular hypoxia secondary to the toxins, leading to acute tubular necrosis, either a reduction in the effective circulating blood volume, leading to overall reduction in the mean arterial pressures. So if you look at the hepatorenal syndrome is not only the interaction between just two organs, the liver and the kidney. The other organs are also involved in the pathophysiology. As I told, the gut bacterial translocation occurs from the gut, which releases a lot of pro-inflammatory cytokines, leading to a acute tubular necrosis similar to that seen in a sepsis-induced ATN. And of course, the heart, it causes cardiomyopathy, reduced cardiac output, leading to hepatocardiorenal syndrome, thus reducing the effective arterial blood volume and leading to decreased renal blood flow. So this is a complex interaction or a multiple interaction from all the organs or the different organ crosstalks, leading to acute kidney injury. So the acute kidney injury in a cirrhotic patient comes from renal hypoperfusion, either due to a decreased renal blood flow or a renal vasoconstriction, direct tubular damage from the toxins or due to a different septic foci, danger signals or inflammation, which either you get from the bacterial translocation from the gut, microvascular dysfunction, which is commonly seen when there is an intense vasoconstriction, and the loss of cardiac output as seen in cirrhotic cardiomyopathy. So coming to the management of HRS, the key management strategy is to maintain an effective circulating volume and maintaining the adequate renal perfusion pressure. How do you achieve this? I increase effective circulating volume by volume expansion, and the preferred solution for volume expansion is albumin, no doubt about it. Initially given at 1 gram per kg for 2 days up to a maximum of 100 grams per day, followed by 20 to 40 grams per day. And assessment of intravascular volume, in particular in this subset of patients, is extremely challenging, and you should use some sort of hemodynamic monitoring in terms of either a dynamic parameter better than the static parameters. You should be using some sort of advanced hemodynamic monitoring to resuscitate these patients, and to maintain effective circulating volume is the prime goal. And apart from this maintenance, you should also try to increase the renal perfusion pressure by achieving a vasoconstriction. So the vasoconstrictor drugs which are commonly used are the terlipressin. You start it at 0.5 to 1 milligram every 4th hourly, and depending on the response, you step up the dose in a stepwise fashion up to 2 milligrams every 4th hourly, up to a maximum of 10 to 14 days. And the basic understanding is, when you increase effective circulating volume and when you cause a vasoconstriction by using terlipressin, the entire splanchnic bed of which is the vasodilatory stage, the entire blood from the splanchnic vascular system moves into the renal system, and the entire effective circulating blood volume is increased into the renal blood flow, thus not compromising on the renal blood flow. Terlipressin is contraindicated in patients having ischemic heart disease, a previous stroke, or a peripheral vascular disease. The alternate options in such conditions is the use of either norepinephrine or a combination of octreotide with midodrine. Midodrine being an alpha agonist, you combine along with a somatostatin analog, that is the octreotide. And the entire target of this management is the goal of achieving more than 10 millimeters of mercury of MAP from the baseline. You try to achieve an increase in the MAP at least 10 millimeters of mercury, or you try to achieve a MAP of at least 70 to 80 millimeters of mercury. So the dose, terlipressin, as I told you, 0.5 to 2 milligrams intravenously every 4 to 6 hourly. Maximum you can try for 14 days. If there is no response, stop the drug and just go for the next modality. And you can also use vasopressin in the non-availability of terlipressin. Noradrenaline 0.5 to 3 milligrams as a continuous infusion to titrate to achieve a MAP of 10. Midodrine plus octreotide, midodrine 7.5 to 12.5 milligrams orally thrice daily can be given to achieve an increase in the MAP of 15 millimeters. And octreotide, of course, 100 to 200 micrograms subcutaneously thrice daily can be tried. So what are the extracorporeal therapies which can be tried when the medical management, the patient is not responding to medical management? Obviously, you think on putting them on the RRT. So if you are thinking to put a patient on RRT who is a decompensated, I think CRRT is the best option. One thing, due to the hemodynamic benefits it offers, and due to the slow solute removal, there are not much of shifts in the osmolars. So the osmolar shift is not as expected as seen in the intermittent hemodialysis, and the incidence of cerebral edema is also reduced when you use a CRRT mode. So the extracorporeal therapies, there are artificial non-cell based and the bioartificial cell based. The most common used are the plasmapheresis or plasma exchange along with an albumin dialysis. The recent one is the molecular adsorbent recirculating system, the MARS, and the bioartificial being the MELS, that is a modular extracorporeal liver support, and the extracorporeal liver assist device. No matter when you use all these extracorporeal therapies, the outcomes in patients when such an advanced renal failure progresses in a patient with a decompensated CLD, no matter if you use these extracorporeal therapies, the overall outcomes doesn't seem to be good. So given the surgical options, TIPS remains an option in patients with type 2 HRS with refractory ascites who require large volume paracentesis, and still this can reduce the incidence of your acute kidney injury in patients with an advanced renal disease. And liver transplantation alone should be considered for candidates with type 1 HRS for less than 4 weeks, and both simultaneous liver and kidney transplantation should be considered when the renal injury continues to sustain and when patient needs renal support for more than 12 weeks. So if you see the diagnosis as a whole, the diagnosis of HRS is a diagnosis of exclusion as previously based on the International Aesthetic Club criteria. But when you have a patient of diagnosis of cirrhosis, just rule out other factors of decompensation, whether the patient is having a hypovolemia, whether the patient is being exposed to nephrotoxic agents, whether the patient actually have another explainable cause of acute kidney injury. And then you go on to the next step, define the baseline creatinine. And after defining the baseline creatinine, see whether the patient fulfills the AKI criteria. If not, consider other kidney diseases and see whether this patient again fulfills the HRS AKI diagnostic criteria. If the patient fulfills the HRS AKI diagnostic criteria, then you can label them as HRS. And it's, as I told, the spectrum of disease, it can be a definite HRS, it can be a possible HRS, or it cannot be a HRS. If it is not a HRS type 1, then do not initiate your vasoconstrictor. If it is a possible HRS or a definite HRS, try to do a staging of the acute kidney injury and achieve the response with the vasoconstrictor and IV albumin. And you can stop if the response is not achieved in 2 to 3 days and step to the next therapy. So to summarize, renal dysfunction is a common finding in patients with an advanced liver disease and is extremely challenging to manage such kind of patients as it is associated with increased morbidity and mortality. And typically, no matter what diagnostic criteria you apply to these patients, the cause of renal dysfunction is always multifactorial. Majority of the times, the reason for acute kidney injury in cirrhotic patients is always multifactorial. And changes in the classification of AKI has made a better understanding to the pathophysiology, and you can start using a novel biomarkers like a cystatin C, NGAL, IL-18, KIN1, which can be helpful in the more future. As of now, still serum creatinine holds best for patients with cirrhosis, and we all know that serum creatinine is also utilized as a marker for renal transplantation as far as MELD score is concerned. It is a part of the MELD scoring system, which is used to prioritize patient to liver transplant. And the most important thing nowadays, people are looking at renal resistivity index, which can identify AKI much earlier in patients with cirrhosis. Of course, this is a difficult part to be observed in patients with cirrhosis, as they have a massive ascites, and you may not find the actual window of the to see the renal resistivity index. Identification and treatment of the reversible factors definitely improve the outcomes. You treat the offending agent, you remove the offending agent, you remove the nephrotoxic agent, treat the underlying sepsis part, probably the outcomes can improve. Albumin and terlipressin is the cornerstone for therapy with hepatorenal syndrome, and it's a proven. There are multiple meta-analysis and randomized controlled trials done in head-to-head comparison with albumin, terlipressin, along with other vasoconstrictor agents like your norepinephrine and midodrine. And till to date, albumin and terlipressin remains the mainstay for the therapy as far as HRS is concerned. And you should consider all the patients with hepatorenal syndrome as early as possible for a liver transplantation, so that it improves the overall outcomes. Thank you.